It is my distinct honor to introduce our esteemed speaker today for our endowed lecture, Dr. Michael J. Blaha. Dr. Blaha is a renowned cardiologist, epidemiologist, and a thought leader in cardiovascular disease prevention. He serves as professor of cardiology in the Department of Medicine at Johns Hopkins University School of Medicine and holds a faculty appointment in the Department of Epidemiology at Johns Hopkins Bloomberg School of Public Health. Additionally, he is director of the clinical research and co-director of the Johns Hopkins Ciccarone Center for Prevention of Heart Diseases. Dr. Blaha represents the fourth generation of physicians in his family. After earning a BS in pre-medical studies and classical civilization at the University of Notre Dame in 2001, Dr. Blaha went to Vanderbilt University, where in 2006 he received his MD as well as an MPH in clinical epidemiology and biostatistics. Dr. Blaha then completed his internal medicine residency in Osler Medicine House Staff Training Program at Hopkins in 2009 before completing a fellowship in cardiology at Hopkins in 2012. So I met Dr. Blaha first time in 2006 when I joined Hopkins and he joined Hopkins. He was my intern, one of the first intern I had there. So good to see you back here. So prolific researcher and a widely regarded expert in preventive cardiology, Dr. Blaha has significantly contributed to our understanding of coronary artery disease, cardiometabolic risk factors, and the use of advanced imaging for cardiovascular risk assessment. Dr. Blaha has published over 550 scientific articles with a focus on appropriate use of tests and new therapies in the prevention of atherosclerotic cardiovascular disease as a function of atherosclerosis burden. And his work has shaped clinical guidelines and preventive strategies worldwide. He has served as an associate editor of the journal Atherosclerosis and the Journal of Cardiovascular Computed Tomography, associate editor for the Diabetes and Cardiometabolic Clinical Community for ACC.org, and he is a standing member of the Endocrinology and Metabolic Drug Advisory Committee, MDAC, for FDA. He has received multiple grant awards from National Institutes of Health, FDA, American Heart Association, Amgen Foundation, Aetna Foundation, Bayer, and Novo Nordisk. In 2018, Dr. Blaha received Dr. Fred Brancati Award at Johns Hopkins for excellence in mentoring. He has mentored over 30 trainees, many of which have gone on to hold prominent academic appointments. In 2021, Dr. Blaha was named to the Clarivet highly cited researcher list representing the top 0.1% of world's researchers. Dr. Blaha's expertise and commitment to advancing the field of cardiovascular prevention make him an exceptional speaker for today's lecture. Please join me in welcoming Dr. Blaha.
Thank you so much. All right, do a mic test. Am I amplified? Perfect. Thank you so much for that kind introduction. I do remember we were just talking about the fond days of 2006 when I was an intern on the Osler Medical Services learning about internal medicine. Even then, I actually had an interest in preventive cardiology, which really went back years for me, even in my college days. So what I'll be talking about today are current controversies in primary ASCVD prevention. I'm going to take an image-guided approach. So hopefully it's going to be extremely clinical. So everyone in the audience will say, well, that case I'll see every day in my practice, and hopefully I'll walk away with some different framework for approaching cases in practice. So we'll be case-based and imaging-guided. So here are my disclosures, many of which you just heard about. I'll mention that I'm on the executive academic steering committee for a Novartis trial, which I'll actually mention at the end of the talk. Okay, so here's the case. So at least at Johns Hopkins, we always like to start with a case. That's a tradition to start grand rounds with the case. I always like to say, as a preventive cardiologist, my cases are quite simple. They're not the unusual cases that you tend to see at a grand rounds on an unusual condition. Mine are by design a case that you'll see every day in practice, or you're going to take your kid to the soccer game and someone will say, hey, I heard you're a cardiologist or an internist. Let me ask you a quick question. So let's consider this, a 55-year-old non-smoking, non-diabetic or no diabetes man with good diet and exercise habits but has a family history of premature coronary disease in his father. And when he gets his basic risk factors done, he realizes the blood pressure is a little high. His HDL is good, but his LDL is a little high too. Once again, 55-year-old, pretty good diet and exercise habits, been mindful of his health. He has a family history of premature disease though, wants to sort of know, am I going to get coronary disease too? And has, we'd agree, borderline risk factors untreated because he considers himself healthy. So hopefully, does everyone recognize a case like this? Hopefully everyone does. I feel like I get asked this all the time. Like every time I go and someone finds out I'm a preventive cardiologist, I hear a case kind of like this. But here are some controversies. So what is this patient's risk, right? Hopefully everyone's thinking of that in their head right now. Is this a high-risk patient? Is this a low-risk patient? And I think almost everyone in the room would agree that it's neither the highest risk case they've seen or the lowest risk case they've seen. So what should this patient's LDL goal be? He asked, well, what should my cholesterol be? How are you going to answer that question? Should I take an aspirin? I'm sure you've heard that question before. Should I take an aspirin? What should my blood pressure be? And then I heard this thing called a lipoprotein A test. Should I get one of those done? So hopefully everyone agrees that these are 5 questions that you'll get all the time in practice. These are things I think about every day. So I try to spend a lot of time thinking about things that every one of us experience, either in the clinic or even outside of the clinic. You get asked as a leader in your community about these questions. Okay, so let's start out with risk assessment. Okay. So as you've known for a long time now, since 2013, the American Heart Association and American College of Cardiology have encouraged us to use their risk estimator, which is referred to as the pooled cohort equations. This was a mild improvement over the old Framingham risk score, which is a risk factor-based score to figure out the 10-year risk of an atherosclerotic cardiovascular disease event. Basically means heart attack, stroke, or a cardiovascular death. Now, this was billed as an improvement over the Framingham risk score that existed since 1998, which it was. But in general, it was quite similar. This ASCVD risk calculator, the pooled cohort equations, used the same risk variables as the Framingham risk score did to come up with the 10-year risk. The innovation was they added separate accounting for race. For example, they used a more diverse sample in the derivation. But really, this is what they came up with. Age, sex, race, total cholesterol, HDL, systolic blood pressure, treatment terms for high blood pressure, yes or no for diabetes and smoking. So while there were some improvements there, the actual structure of risk prediction didn't change that much. Still a traditional risk factor-based approach. And if you plug the patient in, or this is a woman that was 55 years old, this is exactly like our case. But if you were to plug in, what you can get is a 10-year risk of your patient, and you can get also what the patient's risk would be if they had truly optimal risk factors. And here I'm just making the comparison that race is accounted for, at least in this particular model. Okay, so let's go back to our case. So this isn't great the format for shouting out an answer, but maybe we'll get some hands. So who says this patient, and I'll say low risk is less than 5% 10-year ASCVD risk. Who says this patient's low risk? That one vote. Who says this patient, now above 7.5% risk would make them in the intermediate to high risk zone? Who says this patient's intermediate to high risk? Votes. And of course, the alternative is this patient is smack in what's called the borderline risk zone. This person's risk calculates a 6.4% risk of a 10-year atherosclerotic cardiovascular disease event. In the guidelines, it says between 5 and 7.5% is where there's particular ambiguity about what to do with this patient. It says there's moderate evidence to use a moderate intensity statin, lower level of evidence than if the patient was higher risk. So this is the classic patient that there's still ambiguity about. Now, there is a new risk calculator out called the PREVENT equations. This will be the backbone of the next prevention guidelines that you'll learn about in a couple of years. This is put out by the American Heart Association. There's a couple new things about the PREVENT equations, but largely it's still quite similar to the other risk factor-based models. What they've done here is they have an opportunity to include social determinants of health, a hemoglobin A1C, or a UACR. When you have that information, they've taken race out of the equation. But generally speaking, it really operates much like other 10-year risk scores. It uses risk factors measured at one point in time to come up with the 10-year risk. So if we plug our patient into this model, you actually get lower risk estimates. We realize we've been overestimating risk. Our patient has a 10-year risk of ASCVD of 2.7%. A 30-year risk, it also allows you to calculate that, risk of ASCVD of 14.2%. It also allows you to calculate a total CVD, including heart failure. This patient's risk would be 3.6%, or a 30-year risk of 21.1%. So that's a lot of numbers. I think most of us would describe this to a patient. The patient would say, the next thing they say when you say this is, well, is that high? What does that mean? And most importantly, well, if my risk is 3.6, am I in the 3.6 or am I in the 96%? But here's the risk. The question we're going to ask today is this sufficiently personalized enough to really make decisions in practice? These 10-year risk factor models that are based on big populations and really are not as good about saying that, answering that patient's question, well, what about me? Am I afflicted or not? So the goal of much of my career, what I spend a lot of time thinking about, is how can we take population-based risk estimates and personalize them, make them more specific to the patient, and decide who needs what therapies, targeted therapies, aggressive therapies, or maybe doesn't need therapy at all. So I'm going to spend a lot of time talking today about coronary artery calcium scoring. Now, coronary artery calcium scoring has been around since 1988. It is not new, and nor is it fancy. In fact, it's about the simplest imaging test that you could possibly do. All the patient needs is electrodes on their chest to gate this to the cardiac cycle. They don't even need to be in a gown as pictured here. They could be in street clothes right out of your clinic. And for 1 millisievert on any modern multi-detector CT, they can get what's called a calcium score, which is an unenhanced cardiac gated CT scan. And you get images that look like this. Once again, unenhanced. And what you're looking for is calcium. This calcium, of course, highly attenuates X-rays, easy to see. And all you need to figure out is that calcium is within the coronary arteries and quantify it, and you get a calcium score. So once again, this is not a complicated test. In fact, it's designed to be done the same way in Norfolk, from Baltimore, or around the world. The same scanner settings, the same interpretation would be done around the world. So this is not one that varies a lot by where you go even. It should be the same, in theory, everywhere you go. And importantly, this observation dates back to the 1990s from John Rumberger when he did an autopsy study of coronary arteries. And he looked at just 38 patients and made an important observation, which is the amount of calcium in the arteries on the x-axis is directly related to the total amount of plaque. This is a test of plaque burden. The higher the calcification of your arteries, the more plaque you have. This is a test of plaque burden. It so happens that the plaque burden is the number one predictor of cardiovascular disease events, which makes sense. Now, if you go out into the community with a multi-ethnic study of atherosclerosis and you do calcium scoring on otherwise healthy people, you get very disparate results. You get some young patients who have advanced calcium scores. But you also get 20% of people above the age of 75 who have no calcium in their arteries at all. But when you follow those patients up over time, it's the people that have atherosclerosis in their coronary arteries that get the atherosclerotic cardiovascular disease events. Again, makes sense. There was a question at the time when this study was done. Well, if you're young and have a high calcium score, is that something else? Is that a different phenotype? Or if you happen to live to an older age and no calcium, is that really as protective as it seems like it should be? And indeed it was. If you're young and have a high calcium score, you have a high event rate. If you're an older patient and you have a zero calcium score, you have a low event rate. What I took out of this study, the multi-ethnic study of atherosclerosis, amongst other things, is that you have atherosclerotic cardiovascular disease events in proportion to your burden of atherosclerosis, which makes sense. Now, it turns out also that the calcium score is also predictive of other outcomes too, because it really reflects the cumulative damage to your tissues, in this case, vascular tissues, in response to risk factors, genetic, environmental, or traditional. So here in this study, it shows that actually having a high calcium score predicts not only ASCVD, it actually predicts cancer, CKD, being hospitalized for pneumonia, COPD, and dementia. Once again, because it's a measure of tissue injury, cumulative tissue injury to risk factors. So you can do really interesting things with imaging tests. We can actually personalize those risk estimates. And here is a competing risk plot between the two top causes of death in the United States, cancer and CVD. Red, you're more likely to die of cardiovascular disease. Blue, you're more likely to die of cancer. So why is this important? Well, my preventive therapies aren't going to make you live longer if you're going to die of cancer. Likewise, our therapies are going to have a lot more net benefit if you're more likely to have cardiovascular disease. So here you can see, for example, if you're a 55-year-old man, your score is 300, you're way in the red zone. You're much more likely to have cardiovascular disease than you are cancer. Now, if you've managed to live to age 70 with a calcium score of 0, really cardiovascular disease is unlikely to be the #1 cause of death. I've been really interested in this idea, the idea that imaging tests both tell you who's high risk, but also who's low risk. So this is the idea that a calcium score that's 0, in other words, a test that shows no disease in the arteries, is actually one of the strongest negative risk factors against developing atherosclerotic cardiovascular disease. What I like to call the imaging hypothesis of risk prediction is that due to its superior sensitivity, imaging tests for subclinical atherosclerosis are also excellent at ruling out or downgrading risk estimates. This is important. So as opposed to the traditional view of risk factors, we're going to go out and find people who have high risk and treat them more aggressively. Imaging tests also offer the ability to find people who are lower risk than you thought too. And this is really important. If we're just going to go out and find more and more people that are high risk and treat them, why don't we just treat everybody? I think people aren't really looking for that. They're not looking to say, well, let's treat everyone. They're looking to figure out, well, how high risk am I exactly? And that includes also finding lower risk patients. So things like, a biomarker, how often are you getting a biomarker and saying, well, you actually really low risk? You're just trying to find someone more to treat aggressively. Here we can also find patients who are lower risk than you thought, which is very important in my opinion. We've written about this over the years, saying things like the calcium score can find patients and can be used to target subgroups of patients expected to derive the most and the least absolute benefit from therapies. So focusing treatment on the subset of individuals with measurable atherosclerosis might be the most appropriate way of approaching prevention and our resources in prevention, rather than kind of tropes that I hear sometimes of let's treat everyone or treat nobody. I feel like we want to treat the patients that are high risk that are most likely to benefit. So that's going to be the whole theme here. Individualization, personalization. This is what I talked about before. Can we separate out population-based recommendations and find who's really going to benefit? Not only treat them, but treat them very aggressively. And maybe treat patients who are low risk less aggressively. This is the existing cholesterol guidelines, the 2018 cholesterol guidelines. And it says if you're between the ages of 40 and 75, and you don't have familial hypercholesterolemia level LDLs, in this case, they pull out the diabetes too. It says do a 10-year risk assessment with the pooled cohort equations we talked about. Our patients clearly right here in the borderline risk zone. If you're between 5 and 7.5% risk, or if you're between 7.5 and 20% risk, that's the intermediate risk zone. Or it says, also, particularly if you've got so-called risk-enhancing factors, it directs you to the bottom right corner box. Consider a calcium score. If the risk decision remains uncertain, consider doing a calcium score to personalize the risk estimate. So it's in the guidelines, but it's a little complicated. So what are these risk-enhancing factors? Well, if you're borderline risk, you can look over here and say, well, does your patient have a family history of ASCVD? That's the one we talked about. But these questions always come up too. What about you have a metabolic syndrome traits? What if you have CKD? What if you have a high Lp(a)? What if you're South Asian ancestry? How does this work in? It works in the guidelines for pushing you to be more likely to need to personalize risk with a calcium score. So here's what's said in the guidelines. There's a class 2A recommendation. In intermediate or select borderline risk adults, if the decision about, in this case, it just says statin use. We'll spend the rest of the talk about how it's more than just statins, but it says if the decision about statin use remains uncertain, it is reasonable to use a calcium score in the decision to withhold, postpone, or initiate statin therapy. So notice here, it doesn't say in who to treat more aggressively. It says also to who to treat less aggressively too. If you look out in the existing trial literature, which is sparse, where a calcium score was done at baseline, this was the old St. Francis Heart trial. On the left is relative risk reduction. On the right is absolute risk reduction. I guess I can point here. Relative risk reduction, absolute risk reduction. What can be seen is that the higher your calcium score, the more likely you are to benefit from a statin on a relative scale, but also much more likely to benefit on the absolute scale, as far as the blue line showing reduced risk, which makes sense, right? patients with more atherosclerosis are higher risk and are more likely to benefit from anti-atherosclerotic therapy. And a great study from the Walter Reed clinical experience demonstrated this too, where they took patients and propensity matched them to be equally likely to be getting a statin, and then looked by calcium score groups. Calcium score is 0, 100, 100 to 400, or greater than 400. They show that in those patients, the curves didn't separate in the calcium score of 0 group, at least over the time frame of this trial. But they increasingly separated a higher risk of patients who are the more atherosclerosis burden they had, which to me, again, makes sense. Patients develop atherosclerotic events in proportion to their burden of disease, and they benefit from anti-atherosclerotic therapy in direct proportion to their burden of disease. So if we go back to our case, 55-year-old, non-smoking, non-diabetic man, good exercise habits, family history, the risk-enhancing factor, some risk factor values that none of us would feel extremely comfortable with. Here is his 10-year risk, but we decided to be more personalized with this patient and do a calcium score. And it turns out this gentleman from my clinic had a calcium score that was 325. It put him at the 95th percentile for his age, sex, and race. So clearly, I'm going to make the case in the rest of this talk that I'm going to treat him differently than when he walked in the first time and said, well, how am I doing? So if someone stops me on the soccer field and says, yeah, hey, by the way, during halftime, I got a family history. They told me my cholesterol is a little high. What should I do? I don't know how to answer that question until I know how high risk that patient is. So if you go to the MESA risk score, this is a risk tool where you can plug in risk factors in a calcium score and get the patient's risk. I'll show you how to look at this. I plugged in this patient here. In the bottom, this is the risk of the patient if you ignored the calcium score. The top box here, which I'll highlight, is now that you've included the calcium score, so comparative here, what it does is gives you a 10-year risk of a CHD event. Also translate this to a so-called coronary age. This person has the risk of a healthy X-year-old, healthy person of a different age. So because this person's risk factors, they actually have a 7% risk of a 10-year risk event. And according to this model, if you ignore the calcium score, that gives them a coronary age of a healthy 62-year-old. But now that you put the calcium score in the model, the risk goes up to 14%, and they have the risk of a healthy 79-year-old. So these are things that patients understand more than saying your risk is 13.9%. You have the risk of a healthy 79-year-old. I don't have it in here. If his score was 0, he would have had the risk of a healthy 40-year-old or 35-year-old, something like that. So we've personalized that risk estimate to the patient and their burden of disease. And also try to translate that into a number that patients understand. You have the risk of your coronary age is so-and-so. Okay, so how would we treat this patient? How would you treat this patient? Lifestyle therapy only, moderate intensity statin, high intensity statin and an aspirin, or the longest answer is always right. Intensive lifestyle, high intensity statin, aspirin, consider it antihypertensive, and consider a non-statin add-on to achieve an LDL less than 70 or non-HDL less than 100. So sometimes I'll give this list before I give the calcium score and again afterwards. If I give you this before the calcium score, you'd probably been like, well, there would have been a lot of variable answers. Some people would have said, yeah, to put him on a statin. Other people would say, well, he seems healthy enough. Maybe he doesn't need a statin. Now, hopefully you agree once I've given you his calcium score and showed you his risk, at least you're going to be probably in number 2, 3, or 4 here, if not number 3 or 4. And I'm going to try to convince you, at least in my practice, it's number 4. This is a high-risk patient. Okay. So controversy 2 after risk. What about LDL goals? So this was the perception of LDL treatment after the 2013 ACC-AHA guidelines. This is at least what was said by a lot of people, sort of the fire and forget model. It said, hey, it emphasized more who you put on a statin, but it didn't emphasize as much what LDL they should get to. Now, I think the guideline writers wanted to make this simple. Hey, we just want to get the right people on statins and not make this too complicated. But I think we actually want more complexity, at least in the modern era as well. So I absolutely agree that the right people should get on statins, but some people need to be treated more aggressively. So this is the forerunner of the next prevention guidelines. This is the 2022 American College of Cardiology Expert Consensus Decision Pathway on Non-Statin Use. Who's seen this document? Anyone seen this document? So I give the feedback to the ACC that unfortunately no one sees these expert consensus decision pathways, but they are the forerunner of the next guidelines. They say that these will be what the next guidelines will say unless there's new updates. So their interim updates. So not many people know about this, and certainly not many people know about figure 6, which is what I'm showing here, figure 6. Figure 6 is the most important thing in my practice, almost. It's my circle. There we go. Why is it so important? Because I do a lot of calcium scoring. I do a lot of personalization. It says here at the top, let's start in the purple box here. Consider doing a calcium score. We've done that now. Now it says if the score is 0, you're going to consider deferring statin therapy and being more conservative. If the score is 1 to 99 or less than the 75th percentile, put them on a statin, moderate intensity. If the score is above 100 or above the 75th percentile, that's our patient. We'll go through that in a second. They also have a carve out for people whose calcium scores are above 1,000. And I'll tell you the reason for that actually comes a lot from our work showing that these people have risk equivalent of that of secondary prevention patients. So it's going to actually talk about using a PCSK9 inhibitor here to get their LDL down. Let's talk about this group where this patient is. Calcium score greater than 100 or above the 75th percentile. Consider a moderate to high intensity statin therapy. Look at the percent LDL reduction and the LDL achieved. If it's not below 70, add ezetimibe to achieve an LDL that's less than 70. It's pretty simple, right? This patient started out with an LDL of about 145. If you give a high intensity statin, it's usually about a 50% LDL reduction. They'll probably come in back in with about an LDL about 75. I'm probably going to put this person on ezetimibe pretty routinely in my practice to get that LDL less than 70, because this is a patient with a substantial calcification in their arteries. Someone would say, well, gosh, you're treating people really aggressively. Well, I'm treating this patient aggressively. If the patient came in with a calcium score of 0, I would have been much less aggressive. In fact, he said, I want to avoid a statin. I probably would have been supportive of that. But this patient had a high calcium score. So I'm aggressive in a subset of patients that are the highest risk. What it really raises, in my opinion, is this challenging the dichotomy between so-called primary and secondary prevention. Right now, you whip out one set of guidelines and say, here are my patients in primary prevention. Next patient walks in, I'm going to get the secondary prevention guidelines out. But really, it's a big continuum based on how much disease you have, right? This is truly a primary prevention patient. Hopefully his score is 0. He's very active. He just wants to stay healthy. The person on the right has had a heart attack before. Of course, we're going to be aggressive. But what about these patients in the middle? This is my particular interest. They have advanced subclinical atherosclerosis, is what I call it. I think this is the next group we're going to see emphasis from pharmaceutical companies or guidelines or patients, patient groups. For these people with advanced disease, why wait till they're here to treat them really aggressively? Right? Why don't we treat these people aggressively? And that's not to say we're going to treat everyone aggressively. This guy is doing great. We talk about that quickly on this. So we've done a bunch of studies trying to compare the risk of people with advanced calcification in their arteries or vascular system to those people of secondary prevention. So we looked at people above the calcium score of 1,000 here. These people with calcium scores of 1,000 tend to be these people who have diffuse calcification commonly in their aortic valve, aorta, mitral valve too, or diffuse vascular paths. And they have event rates similar to patients that were enrolled in the Fourier trial, which was a study of evolocumab in secondary prevention. It's challenging this paradigm again. These people have just as high as risk as the secondary prevention patients. We repeated this study in the multi-ethnic study of atherosclerosis. If your calcium score was in this 800 to 1,000 range, you had the risk of the people enrolled in this secondary prevention trial. And actually the low risk people of that trial were equivalent of risk of people with scores in the 300 to 500 range. If your score is 300 or 400, you had the risk of someone who enrolled in the trial who just had one prior MI, but didn't have residual multivessel disease. Once again, I'm trying to challenge this paradigm of primary and secondary prevention. So conclusion, LDL goals, I would treat this patient probably with a statin and ezetimibe to get to a low LDL goal. And I would have justified that by probably showing the patient the scan and saying, this is why I'm doing it. You have a lot of plaque in your arteries. That's the substrate for an atherosclerotic disease event. Aspirin, what about aspirin? So do we treat this patient with an aspirin? I bet we get a lot of variability on this question because there's a lot of uncertainty. These were the three trials that came around 2018 that really threw monkey wrench into the aspirin story: ARRIVE, ASCEND, ESPRIT. Largely, they were neutral or weakly positive on aspirin. They started to challenge a lot. These are primary prevention trials in moderate risk patients, diabetes, or elderly, or age 70 patients. And I'm not going to go through in great detail about these trials, but clearly the margin of benefit in the modern era of aspirin has narrowed, right? We shouldn't be giving aspirin to everyone. People should still take it. That's not appropriate. But this did lead to the question, well, does aspirin still work? I sort of laugh sometimes at these questions, right? We know the mechanism of aspirin. The mechanism of aspirin didn't change. But the sweet spot for therapies can change, right? Aspirin still works by inhibiting COX, by affecting the production of prothrombotic prostaglandins like thromboxane. We know how it works. So it's not like aspirin doesn't work, but aspirin works by reducing thrombosis, right, in the setting of a plaque rupture. It doesn't provide benefit to patients who aren't having plaque ruptures. It's not a disease-modifying agent, so you need to use it in patients at high risk of an atherosclerotic cardiovascular disease event, and if you don't, you're going to cause more harm than good. So I would argue we absolutely know this. The patients say, well, I heard in the news that aspirin doesn't work. Well, you heard that the trials showed the therapeutic window is smaller. Now, I'm not going to do a big deep dive on these trials, but I'm someone who still believes aspirin has a role. I won't go through in great detail, but in ARRIVE, there was a 47% relative risk reduction MI. If you looked at the per protocol analysis, lots of people switched over, crossover in this trial, but there's no impact on cardiovascular death. In ASCEND, there's a 26% relative risk reduction in the first 3 years of the trial. That got diminished over time as a lot of people crossed over in this study. And in ESPRIT was a negative study, but there was 11% relative risk reduction if you use the same endpoint as ASCEND. Still a lot of signals for benefit, but they need to be tempered. Here's the most recent meta-analysis that included these trials done in 2019. There's about a 10 to 12% relative risk reduction in atherosclerotic cardiovascular disease events on top in the modern era, on top of statins. It's not 30%, it's not 40%, it's marginal, it's about 10 to 12%. And it's many patients, it's outweighed by the risk of bleeding. But this 10 to 12% is similar to what you see with adding ezetimibe or an SGLT2 inhibitor or a PCSK9 inhibitor, which are in these 10 to 15% relative risk reduction range. One trial of interest, this is a polypill trial that was done, I think in Iran. They randomized people to a polypill versus placebo, and a polypill could be a polypill that had multiple drugs or multiple drugs and an aspirin. So here's the comparison of the polypill versus the polypill with aspirin. And they saw 14% relative risk reduction in ASCVD events in the polypill with aspirin. So once again, more evidence that aspirin provides a modest benefit, but it needs to be balanced. If you take our case, this is a great calculator that was published by a New Zealand group. You can plug in your patient, traits here on the left, and it gives you the risk of a major bleed in 5 years or a cardiovascular disease event in 5 years. And I'm not going to go through this in detail, but the problem with this field is that the same risk factors that lead to increased ASCVD risk increase the risk of bleeding. For this particular patient, we'd estimate that you'd cause 5 major bleeds per 1,000 patients over 5 years, and you'd prevent only 4 cardiovascular disease events. This kind of calculator is helpful for looking at the balance between bleeds and benefit with aspirin. And this is why the new guidelines give a class 2B recommendation for routine use of aspirin in primary prevention, because in most cases, the benefit is balanced by the risk. So, but in the spirit of the talk here, what about if you personalize this risk decision with the calcium score? This was a study that we did in MESA. We excluded people above the age of 70. I think this is a group you need to be very careful with aspirin. We also took out the people with a high risk of bleeding. If they had a history of GI bleeding, we're going to take those out. We're going to look at the people that are more like standard decision you're going to make in practice. And the critical observation for the calcium score is that as your calcium score goes up, your cardiovascular disease event rate goes up, but your bleeding risk doesn't go up. If you smoke, they both go up. If you have hypertension, they both go up. The advantage of an imaging test for atherosclerosis is that it tells you who's more likely to have an ASCVD event, but it doesn't necessarily predict bleeding. So it helps you to find patients who are more likely to benefit. This is a slide that's shown by a lot of people. I'll walk you through this. What this is looking in the colored bars is the number needed to treat, prevent one ASCVD event with aspirin. The red line is the number needed to harm. We're trying to compare these two. And when is the number needed to treat less than the number needed to harm? That's a net benefit. So we looked here in MESA. And if you look here on the left here, this is when you look at people overall here, and blue is ignoring the calcium score. Overall, if you look just treating everyone who fit this study with an aspirin, you'd expect to prevent less events than you would cause bleeds. This is why it says don't use aspirin routinely in primary prevention. You're going to cause just as many bleeds as benefit. If we walk here, let's say about the intermediate risk patient here. Let's just look overall. But overall, if your calcium score is above 100, and certainly if it's above 400, you're much more likely to benefit and prevent an ASCVD event than cause a bleed. But if your calcium score is 0 in orange, you're much more likely to experience a bleed than an atherosclerotic cardiovascular disease event. I routinely take my patients with scores of 0 off aspirin. I do a lot of deprescribing of aspirin. But I also prescribe aspirin quite a bit too, because I get a lot of referrals for patients with very high calcium scores. I like to think that I'm preventing a lot of events. So aspirin is something you need to be careful with and you need to be personalized with. It's probably the prototype of a drug that has a lot of benefit and risk associated with it that you need to be thoughtful about. So once again, this is why the National Lipid Association, a couple other organizations, and hopefully the new guidelines will suggest aspirin for people above calcium scores above 100, but not routinely if you don't have imaging. This was replicated by another group. I'll just show this real quick. The Dallas Heart Study, benefit more than bleeding only when the scores were above 100 in practice. Okay, next question, blood pressure goals. So we know from like the SPRINT study, for example, that higher risk patients benefit from getting to a blood pressure of 120, right? Compared to a more liberal goal, blood pressures achieved in the 130 to 140 zone. The question is, who should we select a more strict blood pressure goal for? Once again, similar to the other studies we've done, here is looking at the calcium score, can risk stratify patients who would be in that zone where you'd consider treating someone, in this case, who is in the pre-hypertension zone, is what they call it, or it used to be called in the guidelines, now stage 1 hypertension. So on the right here, the SPRINT trial, what we did is, well, what calcium score would give you the risk of the average patient in the SPRINT trial? SPRINT trial was about 9,000 patients above the age of 50, and they had to have either a prior MI, prior revascularization, stenting, or have the coronary disease, but no prior event. It turns out if your calcium score is about 250, once again around that 300 zone, you had the risk equivalent of that of someone enrolled in the SPRINT trial. We like to make the extension of that and say, well, our patients with very high calcium scores should be treated to aggressive blood pressure goals. We try to achieve normalization of blood pressure of 120 in our high-risk patients. Once again, if that patient had a score of 0, walked in with a blood pressure of 139, I probably would have said, well, let's check it again, try to reduce your salt intake. They walk in, the calcium score is very high. I'm saying we gotta get this under control, probably at least with lifestyle and pharmacotherapy. All right, so I'm going to close out with a quick discussion of lipoprotein A testing, the other question that you're going to get in practice. So this isn't the venue to talk about lipoprotein A in detail, but Lp(a) is known to be causal via Mendelian randomization studies, causal in atherosclerotic cardiovascular disease and calcific aortic valve stenosis. 1 in 5 people in the world in general have high Lp(a) values. This is extremely right-skewed variable. A lot of your patients will have very low Lp(a) values, and some of them will have extremely high values, 50 times higher than your other patients. This is looking around the world. 1 in 5 in North America have high Lp(a). It's actually up to 1 in 3 in Africa, and higher in South Asia, a little lower in East Asia. But around the world, you'll find high Lp(a) values. Lp(a) probably historically, or through our evolution, had anti-infective properties and other things. That's why we have it to begin with. But nowadays, it's serving mainly, unfortunately, as a pathogenic variant causing ASCVD. Now, 90% of your Lp(a) levels are genetically determined, as you probably know. So that's the next question that patients always ask if it's high. Well, what can I do about it? Unfortunately, there's nothing we really know much to do about it right now. So 90% of LPA is driven by genetics. 20% have a high value, and it's causal in ASCVD. So it explains a lot of family histories where there's not otherwise obvious familial hypercholesterolemia, insulin-resistant syndromes, et cetera. Now, it's extremely complicated molecule. I'm not going to get into the details like Kringle or Pete's and stuff like that. But here you can see a 3-fold increased risk of aortic valve stenosis, 2.5 risk of heart attack if it's high above the 80th percentile, heart failure, and so forth. So there's 2 scales you can measure it in nanomoles per liter or milligrams per deciliter. I'm not sure if you're using the molar assay here. We use the molar assay. Above 75 would be considered elevated, or 30 if you're using the milligram per deciliter scale. I check it in everybody. And now around the world, guidelines are sort of coalescing around the idea of it should be checked once in everybody. Going across here, all individuals in red, who should be checked? The National Lipid Association, the Canadians, the Europeans all say it should be checked once in everyone now. I'm pretty sure the next ACC guidelines will say the same. Everyone should know their LPO/A. Everyone is unanimous in saying it should be checked, and if you have a family history of premature ASCVD. Our patient is in this group. NLA it says also you should measure it in patients with moderate to high risk, of course have a family history of having high LPO/A, et cetera, particularly if you have genetic cholesterol risk. So hopefully you're thinking about checking your LPO/A in a lot of your patients. Now, you might be thinking, well, why check it? It identifies people that are high risk, but I can't do anything about it, right? Well, first of all, you look around the country, very humbling, about 1% of people, actually some samples say 1%, this one says 0.3%. In a more recent study, it said 1% of all people have ever had the LPO/A check. And of those checks, less than 0.1% of all healthcare providers are responsible for those checks. Basically, a few of us are checking it a lot, most of us aren't checking at all, and most patients don't know their LPO/A values. Now, how do I feel about LPA in the imaging era? Well, if you have a high LPO/A and your calcium score is 0, you still mean a relatively low risk patient, but I'm very interested in the patients at the bottom. If you have a calcium score above 100 and have a high LPO/A, you're amongst the highest risk patients we see in primary prevention. So I get a lot of referrals from patients with high LPO/A, family history, high calcium score, and they really need aggressive risk modification. So I'm very interested in the next generation of LPA lowering therapies. I'm actually on the academic steering committee for this trial, as I mentioned, which is a Novartis trial, but there's many trials from many companies out there. This one's called the LPA Horizon Outcome Study with a therapy called pelacarsen. So pelacarsen is an antisense oligonucleotide to the ApoA protein, which is the main protein component of LPO/A. So you go in there and give an antisense oligonucleotide, you reduce the production of ApoA, you make less LPO/As, the LPA goes down 80%. Most of us think, hey, if we can lower LPA 80%, that's likely to be beneficial, but we don't know. So this is a pivotal phase 3 CVOT, cardiovascular outcomes trial, randomizing patients in a double-blind placebo-controlled way to pelacarsen versus placebo. So we have about 8,000 patients. To get in, you had to have a history of an MI or stroke and have a high LPO/A. Every other risk factor is optimally controlled, so it's against the background of aggressive modern medical therapy. It's an event-driven trial anticipating about 1,000 events. I'm not sure if you follow the news. For those of you interested in biotech, it was recently announced that this trial was going to extend likely into 2026. It's event-driven, so we are going to wait for the amount of events pre-specified. And events are occurring a little slower. So we thought it might come at the end of this year, but it's probably going to be early next year. We're going to find out if lowering your LPO/A 80% is beneficial. Cross our fingers that it's beneficial because a lot of our patients need this. If it's not, there's a lot more we need to learn about LPO/A. If there is, then we're going to be able to provide new therapies for our patients with high LPO/A. Okay, so let me close out here with some take-home messages. So first of all, on risk assessment. What do I think we should be doing in practice? We'll start with the traditional score like PREVENT or the pooled cohort equations just to get started. But then you're going to seek more personalization in many patients. And I think the easiest way of accomplishing that right now at low cost is a coronary artery calcium score. We had a nice conversation at lunch before this about also looking at prior chest CTs your patient has had. Your patient might already have all the evidence in their medical record already, whether they have calcium in their arteries, just from a chest CT they had for another purpose. In the future, AI will tell you this, not so distant future. Then let's remove ourselves from the primary versus secondary prevention binary worldview. For this patient's primary prevention, this patient's secondary. We don't treat this one very aggressively. We treat this one aggressively. And consider CAD as a spectrum, finding those patients with advanced subclinical atherosclerosis and treating them earlier, more aggressively. Doesn't mean treating everyone. It means treating in a personalized way. And then we're going to personalize our LDL goals using combination lipid-lowering therapy in appropriate patients. We're going to make personalized decisions about aspirin. Still, the data suggests about 30% of Americans take an aspirin. I think it should probably be about 10 to 20%, but there's still patients I think would benefit from aspirin. And LPA, let's familiarize ourselves and start to check it in our patients. It should be checked once in nearly everyone. Remember, it's 90% genetically determined. You don't need to check it again and again until we can treat it. But you should be aware, your patient should be aware of it. And there's patients with high LPA and a high calcium score, the additive risk in there, it's a very high risk patient. And hopefully help is coming in the form of many therapies coming down the pipeline, the first of which we'll report will be called pelacarsen, which when it comes out will be a secondary prevention therapy, but we'll have a discussion amongst us about what about patients with high calcium scores, and it's an antisensitive leukonucleotide that lowers LPA up to 80%. It's a sub-Q injection once a month. And that's it. Thank you very much.
So for questions, you have these silver boxes in front of you. There's a red circle on it. Press it, hold it as you're asking questions. So, I'll ask for questions. So what, if I'm hearing correctly, what you are saying is that we should add both coronary calcium as well as Lp(a) in routine screening for our patients, because it looks like irrespective of what your calculated risk score is, this additional information helps to tailor therapy.
Yeah, I'm close to recommending that for sure. I'll tell you, everyone in my practice gets an LPA and a calcium score. Now, when you go out into the community and talk about broad screening, I'm a little bit more careful about saying, well, everyone should get the test. With the help of a physician, yes. I do still worry about the paradigm where patients go get a calcium score done. Maybe you don't even see a clinician. They don't get their recommendation what this test really means. And of course, what we're all worried about is patient has a high calcium score. Someone says, well, let's get a stress test. That stress test is equivocal. And they say, well, let's just send you to the cath lab. And then kind of an eager cath lab physician says, well, let's put in a stent. Right? So we need to be worried about that. So in the context of talking to a clinician, I recommend a calcium score in virtually everyone, because you can tell the patient what to expect, what it means. There's a lot of pushback by guideline writers. If we make a wide endorsement, people are going to go get calcium scores and get down treatment pathways that we don't want to go down. But yeah, I think that an LPA and a calcium score in everyone makes sense to me.
Wonderful talk. Thank you so much. One of the things that concerns me about coronary artery calcium scores is the socioeconomic disparity that comes with it. Around here, it's about a couple $100 out of pocket. Usually insurance companies don't cover it. Right. And what is your approach with that patient population? Are you using more of the prevent calculator because it does incorporate social disparities of health? How about high sensitivity CRP, that kind of thing that's a little bit cheaper in patients that can't afford coronary artery calcium?
That's a good question. So you guys heard the question about cost and so forth. I will say at Johns Hopkins, it's $75 to get a calcium score. And usually it's in the 75 to 150 range, but it certainly varies where you go. On the grand scheme of things, it's not an expensive test. It's a relatively cheap test, but you're right, it has cost associated with it. And calculating someone's prevent risk score is free. So I don't find it a big barrier where I practice, honestly, because it's so inexpensive, relatively inexpensive, but that is a concern. And there was a neat study that they did in Cleveland through Case Western and University Hospitals, where they said, well, we're going to start a program. They got endorsement from the higher ups to do this and say, we're going to offer it for free. And they did get more low socioeconomic status people to get calcium scores. So the cost is a barrier. It's not a huge barrier, but it is a barrier. That was a cool study. Maybe we should just offer it for free. I wish we could do that. To me, CRP, things like that don't add a lot of value. There's still some cost there, and it just doesn't add that much. So yeah, you don't need a calcium score. You can get a lot of the way with just a simple prevent risk score, especially if the question is just, do you need to be on a statin or not? Now, a lot of our patients are asking for more personalization, then maybe you can approach that topic next. But yeah, I think a starting point should be, we're not doing a good enough job, just the simple high prevent risk score, are you on a statin? But of course, any of these personalization discussions could miss the forest for the trees by saying we're just missing a lot of patients out there who don't even see the doctor. We need to do a better job with pop health and individualization once they see you in practice. But it's a great point. So it is a barrier. It's not usually covered by insurance. And the reason why actually is because it's so inexpensive to begin with, that many, amongst things I've heard, that if it's covered by insurance, in fact, when it is covered by insurance, usually we bill insurance $300 for the test. This is one of the ironies. If it's covered, all of a sudden it becomes a more expensive test. If it's not covered, we can offer a cash at a relatively low price. So anyway, it's a good point.
It was a wonderful talk. I didn't know Dr. Drew, and he would have been enthralled. The party line of an LDL for secondary prevention is less than 70, but the Improver trial suggested it should be closer to 40. What are your feelings with established atherosclerotic heart disease?
Yeah, LDL goals. So there's no question that the next, in my opinion, that the next prevention guidelines will say less than 55. In fact, this document, the 2022 Expert Consensus Decision Pathway on Non-Statin Use for the existing ASCVD, which I didn't cover, says less than 55 if you're in the very high risk group, which means recent event in the last 12 months, multiple events, or polyvascular disease, like you have disease in more than one vascular bed, like carotid and coronary, for example. Everyone else is at least less than 70. So for sure, the next ones will say less than 55 for the highest risk patients. What I'm most curious about is what are they going to say about the patients with very high calcium scores? I would encourage them to be just as aggressive. So in my patients with very high calcium scores, I'm actually shooting for less than 55 based on the evidence. I'm not sure the guidelines will go that far. They'll probably say less than 70 in that the zone I'm talking about. But in my practice, we go less than 55 based on the evidence.
We have people on Zoom also, so let me bring Mike to you.
My question is, if you get a calcium score, say in the patient who you mentioned earlier and their score was maybe 20 or 30, when do you recommend repeating it and what's the time frame for that?
This is a great question. And there's some uncertainty here. And I want to specify, I guess, which patient we're talking about here, because it does matter, right? First of all, if they're a young patient, let's say you did a calcium score at age 40 and it's 20, they're above the 75th percentile, then you're already going to be on a pretty aggressive treatment cascade. I don't always repeat that if I'm already going to be aggressive. Actually, in my practice, I commonly will check it once because there's some data that faster you progress, the higher risk you are. You don't need to because you've sort of already labeled that patient as a higher risk patient. Now, if they're a middle-aged patient, their score is 20, I think it's a little more, it's not as helpful, right? Because you expect the score to go a little up with age, it's still pretty low. So I'll repeat it in 3 to 5 years. The evidence suggests it doesn't change enough on a yearly or bi-yearly basis. Like it's not like a mammogram, we should check it. So the question applies to both people with low positives, like you asked, and zeros. The next question usually comes up, well, what if there's 0? When do I recheck it? About 1 in 4 patients or 1 in 5 patients will convert to a positive score in 3 to 5 years. This does not need checked every year. So I usually check it in 3 to 5 years. That's probably what the new guidelines will say. So what I call low positives or zeros, I'll check in 3 to 5 years if it'll change my management. Now, I will say though, be very mindful. I'll see this sometimes. If they're 40 years old and they have a score of 20, they're high risk already, right? Sometimes I'll see those patients not treated aggressively enough. That's like my wheelhouse. 40 years old, already some atherosclerosis, we can make the biggest difference for that patient by treating, not waiting for that score to go up higher. But it's a great question, 3 to 5 years.
Go ahead.
Thank you for the presentation. My question is related to fitness, cardiovascular fitness as another independent risk factors for cardiovascular disease. And so if I recall correctly, there was some evidence to show that athletes, for instance, they actually have an elevated calcium score. Yeah. And so what do you do in those individuals who might be athletes or ex-athletes? Yes. Do you still take that into consideration or it doesn't matter?
This is another great question. And I'm going to specifically cite the ultra endurance athletes, right, which is where the data is strongest. So the question is, in patients who are endurance athletes or ultra endurance athletes, there's this observation of higher calcium scores. And that's been a very consistent observation. They also have more likely to have subclinical scar on a cardiac MRI, more likely to have detectable troponins after long runs, et cetera. So there's probably some subclinical vascular injury for extreme exercisers, and they have higher calcium scores. And the calcium score remains prognostic in those folks. However, the ultramarathon runner who's got a calcium score of X compared to the average person with a score of X will have a much lower event rate, buoyed by their fitness. So it is like a separate axis. Yeah, physical fitness is extremely important for lowering event rates and things. But the calcium score that's observed in endurance athletes, in my opinion, is real atherosclerosis, and it's prognostic. But once again, the event rates are much lower than people with lower fitness. So I still I don't necessarily tell my patients who are ultramarathon runners to stop doing it. I do usually do a calcium score on them. I'll treat them. But generally, they're getting health benefits from doing that. But the evidence would suggest you're probably getting most of the health benefits from at least moderate exercise, right? So, I don't have a strong stance against not recommending it, but I do think there is a signal for higher calcium scores in those patients. But physical fitness is extremely important too. So I like to spin that sometimes and say, well, what about your patient with high calcium scores who didn't exercise and says, now I want to exercise? Is that safe? Absolutely. We should be encouraging them to exercise because that fitness is what's going to keep them have lower event rates despite their high calcium score. So they don't necessarily need to do marathons, but they can exercise. But I do think that ultra exercisers, that's where the data is mostly, not as much like former NFL players or NBA players or whatever. It's usually seen in the ultra endurance athletes where you see that signal. And I'm cautious with those patients.
Other questions? So, one perhaps a little bit philosophical question. I like that your slide where you pointed out there's a risk factor, a negative risk factor.
Yeah.
And I'm wondering if you would like to expand a little bit more on the concept of negative risk factor.
Yeah, so this has been a big area of my interest because a variety of things. I made reference to one of the things I was observing early in my career was every new test that came out was like, the rationale was always, we can treat more patients, we can treat more patients, we can treat more patients. And I said, well, why do we need a test necessarily to tell us to treat more patients? I also want to find out who's actually lower risk than we thought too, because you could search around forever and finally find a biomarker that's elevated if you really wanted to treat a patient. So I'm very interested in this idea that there's some patients, we observe them all the time in practice, who just don't get as much disease as we're expecting, right? Patients with super high, if you go to familial hypercholesterolemia clinics, and this is the thing that we have to sort of contend with, if you go to genetically proven FH patients, still 40% of those patients have a calcium score of 0 in their 50s to 60s. Despite the fact they might have had LDLs in the 300-400s. And it's really something that we just don't understand, right? Clearly, we can't explain everything with just the risk factors, just like we have the smokers who don't get COPD and whatnot. This is why I think individualization is so important. And it just leads to this philosophical question, like you said, of we spend a lot of time looking for susceptibles. We don't spend much time thinking about resilience. We don't understand resilience very much, but it definitely exists out there. In fact, when we were doing our preventable trial, I was talking about that earlier, about 20% of people above the age of 75 in that trial have a score of 0 still. So I think the idea of finding patients who are lower risk, it's incumbent upon us to do that as well. If you're just finding people that are higher risk, I'm sure really that's not true risk stratification. True risk stratification is finding patients with lower risk than you thought and higher risk than you thought. So this whole concept of calcium score of 0 is important. Now, as you may know in the chest pain guidelines, if you have low risk chest pain, it says there's a class 2A recommendation to do a calcium score. And if the score is 0, for example, you can be done with your evaluation of low risk chest pain. It's extremely unlikely your low risk chest pain patient. That means, I don't mean ST elevations in the emergency room. I mean atypical chest pain, maybe in your outpatient setting, calcium score 0. You can save resources by being much more conservative in the management of these patients. So the idea of finding the patients who are actually protected against the disease is extremely powerful too. So we don't overspend, overtest, and these sorts of things. So I'm very interested in this idea too. And I think it's the counterpoint to someone saying, well, as I mentioned, oh, you just want to treat, a patient says, well, you just want to treat everyone with meds. No, actually, there's a lot of patients I actually don't want to treat with meds. Want to be more focused with this. So that's what a calcium score allows you to do.
Thank you.
Thank you so much. It was a wonderful talk. it's kind of an hypothetical question, but going back to your presentation, in patients who have low risk calcium score, acceptable lipid profile, and their lipoprotein A is elevated, I think, how do you deal with such patient population? Yeah. Because their therapies to offer are limited, and it won't go down with lifestyle changes, right?
Yeah.
So how would you proceed with these patients?
Yeah, this is tough. I'm very interested in this population too. So this is the patients who have, let's say, a calcium score at 0 but have a high LP(a), and they're common because 1 in 5 patients has a high LP(a), right? It's particularly challenging to find them at a younger age too. But their score is 0. I will follow them with repeat calcium scores to see if they, if they convert. Can't really do anything like you said about LP(a) anyway. Maybe I'll put them on a statin if I think they're higher risk. But this is a challenging group that we need to learn more about. But the reality is, even though LP(a) is a strong risk factor, there's still many people who don't get atherosclerosis despite a high LP(a). Another one of those challenging resilience things that we need to learn about. So I follow them in my clinic, but I don't treat them that aggressively necessarily. It's just one of many risk factors. Or I'll put them on a statin and that's it. Now, I want to learn a lot about these trials, right? If the trials say that it's overwhelmingly beneficial to lower the LP(a), I think we're going to shift the thinking on that quite a bit. There's oral LPA therapies in the pipeline too. So someday it might not be as complicated as an anti-set oligonucleotide. Maybe there's an oral small molecule that we could give. So this will change in the next 10 years. I think that's interesting.
It's 104, so
we just have one quick question.
We have one.
It's a good one.
So, recent guidelines have come out regarding treatment of hyperlipidemia and HIV infection because HIV is considered as its own risk factor.
Yeah.
And so, none of these guidelines really address that adequately. So I'm wondering, it sounds to me like we should be more aggressively working up people who have HIV infection. We should be checking maybe coronary calcium scoring and LP(a) in those patients.
Yeah, so I'm pretty sure the next guidelines based on the REPRIEVE trial will say that all HIV patients should get a statin. I think based on REPRIEVE, I think that's the pitavastatin study. But I still think the calcium score has benefit in these patients because you need to decide they need additional therapy to achieve lower LDL goals. They need an aspirin, et cetera. So I still think I think they're likely to be recommended be in the group that are recommended all for a statin. But I still, in my practice, get a calcium score because it drives so many other decisions beyond just the statin question. But I do think that trial was pretty convincing that they were at least moderate risk. But I think it makes the case that probably everyone with HIV should be on the statin.
All right. Thank you, everyone, for joining.